Hello everyone. Today we are going to discuss about echocardiographic assessment of mitral regurgitation. So our learning objectives will be to understand the anatomy of the mitral valve, to understand the various etiology and mechanism of mitral regurgitation, and to determine the severity of MR. So the mitral apparatus consists of anterior and posterior mitral valve leaflet, mitral annulus, chorda tendinis and papillary muscles. So anterior leaflet is about 2-fold longer and it occupies around 1/3 of the circumference of the mitral annulus, while the posterior leaflet is shorter and it occupies 2/3 of the mitral annulus circumference. Overall, the area of both the leaflets are equal. So when viewed from the LA side, the mitral valve surface has two zones, one smooth zone and another rough zone. The smooth zone corresponds to the LA aspect of the mitral leaflets and the rough zone corresponds to the coaptation zone. The length of the coaptation zone in normal mitral valve is around 8 to 10 millimeter. Further, both the AMVL and PMVL are divided into 3 scallops each, A1 and P1 being the lateral most scallops and A3 and P3 being the medial most. When viewed from the parasternal long axis view in transthoracic echocardiography, we can appreciate the A2 and P2 segments of the AMVL and PMVL, and when we tilt the probe towards the aortic side, that is laterally, we can identify A1 and P1 scallops, and if we tilt the probe towards the mitral valve, that is medially, we can open up A3 and P3 scallops and we can assess the location of the MR accordingly. In parasternal short axis view, we can identify all the 6 scallops of the mitral valve, and in apical 4 chamber view, A2 and A3 segments of the AMVL and P1 segment of the PMVL are seen. In bicommissural view, that is apical 2 chamber view, we can identify P1 and P3 segment of PMVL and A2 segment of AMVL, and both the commissures are visualized in this view, anterolateral as well as posteromedial commissures. So from etiologic point of view, MR can be broadly divided into primary MR and secondary MR. The primary MR results primarily from the abnormality of the leaflets. The examples include mitral valve prolapse and other myxomatous degeneration of the mitral valve, calcific degeneration of the mitral valve, which is seen mostly in elderly patients, infective endocarditis and its various complications, rheumatic heart disease and other collagen vascular disease, and some congenital anomalies like cleft mitral valve leaflet and parachute mitral valve. Secondary MR results from ventricular remodeling either from ischemic or non-ischemic cardiomyopathy, and apart from cardiomyopathy, annular dilatation can also result in secondary MR, which is seen in patients with chronic atrial fibrillation and patients with restrictive cardiomyopathy. It is important to note that both the primary and secondary form of MR can coexist in a particular patients. For example, a patient with mitral valve prolapse can develop ischemia and develop secondary MR, and similarly a patient with ischemic cardiomyopathy can develop primary MR because of rupture of the chordae or papillary muscle, which can lead to flail mitral leaflet. So both the etiology can coexist in a particular patients. So according to the Carpentier classification, the mechanism of mitral regurgitation can be broadly divided into 3 types. Type 1 MR results in the presence of normal leaflet motions. The example includes annular dilatation and perforation of the leaflet in patients with infective endocarditis. Type 2 MR results from excessive leaflet motion. The classical example includes mitral valve prolapse and flail mitral leaflet in the presence of rupture chorda or papillary muscle. In type 3 MR, there is restriction in the mitral valve leaflet motion either during opening or closing. Type 3 MR results from restrictive opening of the mitral leaflets. The classical example is rheumatic heart disease, where there is thickening and fusion of the leaflets as well as subvalvular apparatus. The type 3B MR results from ventricular remodeling, which causes tethering of one or both leaflet and thus results in MR. So we will briefly discuss some of these mechanisms. MVP is one of the common cause of mitral regurgitation, and MVP results from prolapse of one or both mitral leaflets beyond the plane of annulus in the parasternal long axis view. Most often there is isolated prolapse of the PMVL, but in some cases there is prolapse of both the leaflets. So to understand the MVP, it is very imperative to know the anatomy of the mitral annulus. Mitral annulus is not a circumferential ring, it is rather a saddle shaped structure with two peaks and two valleys. When we image mitral valve from the apical 4-chamber view, the ultrasound plane cuts through the two valleys of the mitral annulus, and hence in this view the mitral leaflets can be seen moving towards the LA beyond the plane of the beyond the plane of the annulus, even in the absence of mitral valve prolapse. When we image mitral valve from parasternal long axis view, the ultrasound beam penetrates through the peaks of the mitral annulus, and hence this view is recommended to assess the MVP, because if the leaflet prolapse in this view, then we can clearly say that the mitral valve has truly prolapsed beyond the plane of annulus into the LA. When there is a prolapse of anterior mitral leaflet, the MR jet is usually directed posteriorly, and when the PMVL is prolapsed, the jet is directed anteriorly towards the aorta. With 3D reconstruction, we can actually determine which scallops are prolapsing exactly, and this has important surgical implication during mitral valve repair. So flail leaflets occur when not only the body but also the tip of the leaflet is directed towards the LA. In mitral valve prolapse, only the body is directed, falls into the LA, the tips are still towards the LV. In flail, the tips are directed towards the LA, and it usually results in torrential MR. It happens most often because of the chorda rupture in patients with infective endocarditis or in patients with acute MI. So functional MR results from abnormal function of a normal leaflets in the setting of impaired ventricular function, which results either from ischemic or dilated cardiomyopathy. There occurs imbalance between tethering and closing forces of the mitral valve. The tethering forces like annular dilatation, LV dilatation, papillary muscle displacement and LV sphericity. So these forces are increased in patients with ventricular remodeling, and closing forces are reduced in patients with reduced LV contractility, global or local LV dyssynchrony, which results from papillary muscle dysfunction. So with global LV remodeling, there occurs LV dilatation, increase in the LV diameter and volumes. The LV sphericity index also increases, and with local LV remodeling, which is seen in the setting of ischemia, there is apical displacement of the posteromedial papillary muscle and second order chorda tendineae. There is also increase in interpapillary muscle distance. So both these global and local LV remodeling causes mitral valve deformation and interferes with the mitral valve closure. The tenting area and coaptation distance increase in these patients. Most often the PMVL gets tethered and there is tenting of the AMVL, which interferes with the mitral valve closure and results in MR. As we can see here, as the tenting area increases, the ERO, that is effective regurgitant orifice, also increases. So now let us move to the assessment of MR severity, which is a very important part of MR assessment. A comprehensive approach is needed with the help of various semi-quantitative and quantitative parameters to assess the MR severity. The most basic assessment being the assessment of LV diameter and volumes. So as the MR severity increases, the LA and LV dimension increases, particularly in patients with primary MR with normal LV function. However, in patients with secondary MR, the LA and LV can be dilated because of the secondary etiologies like ischemic or dilated cardiomyopathy, and in these settings the diameter of LV and LA are not very specific for severity of MR. So Doppler modality is one of the most common used method for evaluation of MR severity. It includes color flow as well as continuous and pulse wave Doppler assessment. Color flow mapping is the most commonly used method, and we assume here that as the severity of MR increases, the size and extent of the MR jet into LA also increases. However, the relation between jet size and MR severity is not always linear. For example, in patients with increased LA pressure and in those patients with eccentric jets which hug the LA wall, or in patients with hugely dilated LA, in these patients the These patients may exhibit smaller jet areas despite severe MR. As we can see here, patients with eccentric MR can have very small area compared to the central MR despite the MR being very severe. So when the color flow area is more than 40% of the total area, the MR is said to be severe. In patients with mild MR, the MR jet occupies less than 20% of the LA area. There are certain factors that needs to be kept in mind while assessing MR severity with the help of color flow mapping. The important one being the Nyquist limit. The Nyquist limit should be adjusted at around 50 to 60 centimeter per second. As the velocity is reduced, the lower velocities are also included in the MR jet, which appears the MR jet falsely enlarged. And in addition, the blood cells which are already present in the LA, they get entrained by the regurgitant jet and may reach the minimal velocity if the Nyquist limit is set low, and thus the MR jet may falsely appear enlarged. Color gain should be optimally adjusted to eliminate the random color speckles. Also, the jet area is inversely proportional to the pulse repetition frequency. So these machine related parameters should be adjusted carefully while assessing MR. Patients with slit-like orifice and those with multiple separate jets can have larger jets in color flow mapping. Ultrasound attenuation can occur especially in patients with large body habitus or from an interposing highly reflectant structure such as calcium or mitral prosthesis, which will interfere in the assessment of the jet size. The jet will appear falsely small. Transducer frequency also has a dual effect in color flow jet area. The higher the frequency, the larger the jet appears, as we can see in during transesophageal echocardiography. With higher frequency, there is a significant Doppler shift at lower velocity. So the RBCs which are moving at lower velocity also appear in the color flow jet. On the other hand, when we use a higher frequency probe from the thoracic view, then these higher frequencies get attenuated at the depth increases, and the jet may falsely appear small. So these things should be kept in mind. Another important parameter in color flow mapping is vena contracta width. Vena contracta is the narrowest portion of a jet that occurs usually at the ERO or just downstream the orifice. The cross-sectional area of the vena contracta represents the measure of ERO. The size of VC is independent of the flow rate and driving pressure from the LV for a fixed orifice, and this is one of the advantage of vena contracta width measurement. However, the diameter of vena contracta may change during the cardiac cycle. So vena contracta is usually measured in the parasternal long axis or apical 4-chamber view. It is measured perpendicular to the regurgitant jet. The color flow sector should be kept as small as possible so as to obtain better resolution, and zoom mode can also be used. When the VC width is more than or equal to 7 mm, the MR is considered to be severe, and with mild MR the VC width is less than 3 mm. It is very simple quantitative measurement and useful in both central as well as eccentric jet. However, it is not useful when there are multiple MR jets, and it can overestimate MR when the jet is not holosystolic, as is seen with MBP. PISA method is another color flow method. The PISA method is based on the properties of the flow dynamics and continuity equation principle. The main goal of PISA method is to calculate the ERO area. This method is based on the principle that the flow rate is same at all the points along the circuit. In our example, this circuit is regurgitant jet. So the flow proximal to the ERO through the regurgitant orifice should be equal to the flow distal to the regurgitant orifice. So what is PISA? So as the blood flow converges towards the regurgitant orifice, it produces small hemispheric shells of increasing velocity and decreasing surface area. So color flow mapping offers us the ability to image one of these hemisphere during the aliasing phenomena. So according to this principle, the PISA flow should be equal to the MR flow through the ERO. And with the help of these mathematical formulas, we can calculate the ERO area. So to obtain the ERO, with PISA method, apical 4-chamber view is used. The color frame is chosen according to the maximal MR jet velocity in continuous wave Doppler, and zoom mode is usually used to obtain better PISA. Once the frame is selected, the color baseline is lowered in the direction of MR jet at around 20 to 40 centimeter per seconds, and when the color flow shift from yellow to blue, at that point we measure the PISA radius from the mitral valve tip to the hemisphere. So this is how the frame is selected. The frame should be selected which corresponds to the maximal MR jet velocity in continuous wave Doppler signal, and once the frame is selected, the PISA radius is measured, and with this measurement we can get ERO, and once the ERO is measured, we can calculate the regurgitant volume by multiplying it with VTI of the MR signal in continuous wave Doppler jet. So severe MR according to the volumetric assessment by PISA is said when the regurgitant volume is more than 60 ml per bit, or the regurgitant fraction is more than 50%, and when ERO is more than 0.4 centimeters square. There are certain limitations of this PISA method. Here we assume that PISA is always hemispherical, which is not always the case. Sometimes there are multiple or eccentric regurgitant jets, in which case the PISA is not very useful, and in patients with only late MR, this method will overestimate the mitral regurgitation. So in continuous wave Doppler, we mainly look at the two parameter of MR, that is density of the jet and the shape of the MR signal. Higher the density of the MR signal, higher the severity of MR, and as the severity of MR increases, the jet becomes more triangular or V-shaped, because with the increase in severity of MR, the LA pressure becomes equal to the LV, becomes very high in the late part of the systole, and hence the gradient is obliterated in the later part of the systole, which produces characteristic V shape of the MR signal. In patients with mild MR, the jet is very faint and symmetrical, and in patients with severe MR, the jet is dense and asymmetrical or V-shaped. In pulse wave Doppler, we usually assess transmitral flow velocity and pulmonary venous flow signal. As the MR severity increases, the flow rate across the mitral valve as well as the velocity across the mitral valve also increases, and the E velocity of more than 1.2 meter per second is a supportive sign of severe MR. However, the E velocity also depends on the LV relaxation properties and filling pressure. So high E velocity is not very specific in patients with secondary MR or in patients with atrial fibrillation and mitral stenosis. However, there is a fairly good correlation between the peak E wave velocity and the severity of MR. Normally, the pulmonary venous flow has a systolic dominance, means the pulmonary venous flow is more prominent during systole as compared to the diastole. As the mitral regurgitation severity increases, the systolic flow increasingly gets blunted, and in patients with severe MR, the systolic flow become reversed altogether. However, blunting of systolic pulmonary venous flow can be seen in patients with AF and those patients with elevated LA pressure. So it is not a very specific sign of severe MR, but systolic flow reversal in more than one pulmonary vein is a very specific sign of severe MR, and its absence does not rule out severe MR. So accordingly, we can get false positive results in patients with eccentric jet which is directed into one of the PV pulmonary vein, and false negative results can be seen in patients with severely dilated or very compliant large LA. So apart from PISA method, there are other volumetric measurements. So volumetric method is based on the principle of conservation of mass, and according to this principle, in the absence of valvular regurgitation or intracardiac shunts, the stroke volume through each of the mitral valve should be equal. So accordingly, if forward flow is 60 ml and regurgitant flow is 40 ml, then the transmitral flow should be 100 ml. So according to this principle, if we measure flow through two valves and we subtract one from the another, we can get the regurgitant volume. So in assessment of MR, we measure the transmitral flow, which is transmitral stroke volume, and LVOT flow, which is transaortic stroke volume, and the difference between two gives us the regurgitant volume through the mitral valve. So once we get the regurgitant volume, we can calculate the regurgitant fraction as well as ERO area. So specific signs of severe MR includes large central MR more than 10 centimeters square, and the MR jet area which occupies more than 40 to 50% of the total LA area, the eccentric wall hugging MR or swelling of jet in the LA, vena contracta width more than 7 mm with large flow conversion, and systolic flow reversal in pulmonary veins. So these are very specific signs of MR. There are supportive signs which includes dense and triangular color, continuous wave Doppler signal, E wave dominant velocity more than 1.2 meter per second, and enlarged LA and LV, particularly with normal LV function in the setting of primary MR. Quantitative parameters for severe MR includes regurgitant volume more than 60, regurgitant fraction more than or equal to 50%, and ERO area more than 0.4 centimeters square. In patients with mild MR, the jet area is usually less than 20% of the total area, vena contracta is less than 3 mm, and there is minimal or no flow convergence during the regurgitation. There is also systolic dominance flow in the pulmonary vein Doppler signal, and A wave is dominant in the mitral inflow signal. The continuous wave Doppler signal is also very soft and parabolic in shape, and the LA and LV are not dilated. The quantitative parameter for mild MR includes regurgitant volume less than 30 ml, regurgitant fraction less than 30%, and ERO area less than 0.2 centimeters square. And anything in between these value is considered to be moderate MR. So how do we assess the clinically the MR severity? So first we look for the specific signs of either severe MR or mild MR, and when more than or equal to 4 criteria for either severe or mild MRs are met, the MR is said to be either severe or mild respectively. And when there are only 2 or 3 of these criteria present, then we proceed for the quantitative assessment, that is ERO area measurement, regurgitant volume and fraction measurement. And after this measurement, the MR is re-quantified as mild, moderate or moderately severe or severe. And when despite this assessment, if we get indeterminate values for the MR, or in patients with poor transthoracic echo quality, we can proceed for transesophageal echo or cardiac MRI for MR severity assessment. So all these things we learned so far was for the chronic MR. In acute MR, the things are very different. The patients with acute MR, there is usually hypotension and high LA pressure because the LA doesn't get enough time to dilate in patients with acute MR. So this results in low driving pressure and therefore the lower MR jet velocity, and accordingly the color Doppler jet which is very large in patients with chronic MR. In acute MR, the Doppler signal is the Doppler jet area is very small, and because of this the MR severity can be underestimated. So to assess the acute MR, one should look for the anatomic aspects like presence of flail leaflets or ruptured papillary muscle, and along with these findings, if the LV is very hyperdynamic, this is strongly a sign of severe MR. Also, the systolic flow reversal in pulmonary vein is usually preserved in patients with acute MR and is very helpful in diagnosis of acute MR. And TE is better in assessing acute MR compared to the transthoracic echo. So blood pressure also has effect in the assessment of MR, and one should always know the blood pressure while doing echo in patients with severe MR. In patients with mitral stenosis, we look at the heart rate, and in patients with mitral regurgitation, we must know the blood pressure. So in this example, there are two different patients. One patient is having systolic blood pressure of 105, and there is another patient with systolic blood pressure of 178. if we look at the color flow jet, we can see the jet area is almost similar in both the patient. However, when we apply the quantitative parameters, we can see that the patient with blood pressure of 105 has regurgitant volume of 42 ml and ERO area of 0.3 centimeter square, and the patient with blood pressure of 178 has regurgitant volume of only 17 ml and ERO area is 0.08 centimeter square. So this emphasizes that higher the blood pressure, higher the overestimation of MR severity just by looking at the color flow. So in this case, one should always look for volumetric parameters. Similarly, in patients with dynamic MR, for example, in patients with MBP and HOCM where the MR is usually confined during mid or late systole, the volumetric parameters should be used, because looking only at the color flow jet will overestimate the severity of MR. So these things needs to be kept in mind in patients with dynamic MR and in patients with high blood pressure. So thank you for your attention.